But now we're in this very good situation where we have very potent, very safe drugs to cure virtually all patients. Now I would say the remaining two challenges in the field are to get the drugs to all the patients and all the carriers before they develop severe liver disease, and secondly to develop a vaccine, because the World Health Organization estimates there's 2 to 3 million new infections every year around the world. So we need drugs to treat the carriers, but prevention is better than cure, so we need a vaccine. Well, viruses evolve with their host, and many viruses cause acute infection and then the body can eradicate them. But some viruses have adapted so well to the host by genetic mutation and adaptation that they can survive for the lifetime of the patient. And HIV is one example, and hepatitis C is another example. And hepatitis C virus, I always think, is the most clever virus because HIV persists by integrating into the genome of our human DNA. Hepatitis C doesn't do that. It's an RNA virus, so it doesn't integrate, but it still persists. So it has a number of very clever mechanisms. It inhibits our immune response, many aspects of the immune response to it. There's evidence that it might be in parts of the body that are protected from the immune response. And there are probably mechanisms that we don't even understand today. But it's a very clever virus, very smart, but finally we've outsmarted it. People infected with the same virus will develop different symptoms. And so the actual human genome will decide, essentially, if it's a serious disease or not. If the immune response in one individual is strong enough, the virus can be eradicated without any drugs. But unfortunately with hepatitis C, that occurs only in a minority of patients, around 1/4 of infected patients. The remaining 3/4 will develop a variety of symptoms depending on the human genetic makeup. Some people will develop rapid, severe liver disease, including liver cancer, whereas others, even though they're persistently infected for life, have very mild disease. And one of our challenges is try to identify which patients will develop serious disease the fastest. And I think it's very important with the new drugs that are now available to treat all of the infected carriers as quickly as possible. Economically, that's a huge challenge for healthcare systems all over the world. But if we only treat those patients with severe liver disease, we will be preventing those patients dying from the virus. But other patients that are carriers will develop serious liver disease while they're waiting for therapy. So it's very important that all HCV carriers get treated as soon as possible. It's hard to predict patients that have mild disease now, what they will do 2 or 3 years from now if they're left untreated. We don't have enough knowledge to say that this patient can be left untreated for 5 years. He or she will be fine. We can predict that most of those patients with mild disease probably will be okay if left untreated, but there's a wide margin of error there. And certainly if I was carrying hepatitis C virus today, I would want to be treated straight away. That is the priority. It's a very expensive burden for healthcare systems, but I think the drug companies need to produce more drugs, which they are. There needs to be negotiations between public governments and drug companies around the world to find a cheaper way to treat all patients. It's dangerous to have a plan where you only treat patients with the most severe liver disease. That is a good start, but very rapidly it needs to be extended to all patients that are carrying the virus, in my opinion. I think for countries that have to be selective about who they give the drugs to. It does make sense to treat the patients with advanced fibrosis first. Fibrosis is a consequence of infection of the liver by the virus, and it's a serious indicator of potential liver disease, serious liver disease. So it makes sense to treat people with serious disease first, but as soon as possible, a mechanism needs to be found somehow to treat all carriers, because a patient that's healthy now may have liver cancer in 3 years' time if they're left untreated. So prioritization of drug therapy is a reasonable strategy for the very near future, but very quickly the drugs have to be made accessible to all patients, all carriers. The first thing I would recommend is to have widespread community screening to detect most of the carriers of Hep C. Because if you can identify most of the carriers, there can be some simple procedures to minimize the progression of disease. For example, a hepatitis C carrier should not be drinking alcohol. And while that takes away some of the joy of living, if you have an infection of the liver, it will minimize the chance that you will develop serious liver cirrhosis and liver cancer. Secondly, there have been 2 good studies published by the United States NIH and the Japanese NIH, and both multi-site clinical studies have shown that something as simple as drinking 3 cups of coffee per day can actually slow down the progression of fibrosis and liver cancer. So these are very simple things that a newly diagnosed carrier can do to minimize their risk of serious liver disease. Thirdly, once a carrier is diagnosed, then that person needs to get therapy as soon as possible. If liver disease is mild, then given the high cost of drugs, they can probably wait 2 to 3 years, but somehow the governments of this world need to work with the drug companies of the world to make the drugs accessible to all of the carriers. The price has to be lower, but then the volume of drug use, therapeutic drug use, increases, and so the drug companies can make their profits and all of the carriers can be protected. So there needs to be a political and pharmacoeconomic solution to this enigma that we are facing. My recommendation to the medical authorities and the politicians in Romania is to make the drugs available now to patients with severe liver disease. In 1 year's time, negotiate a price with multinational drug companies that is much lower than what it is now, so that those drugs can be made available to the patients with mild disease but which are at risk of developing serious liver disease. I think the message to the drug companies should be lower the price, but because the volume of uptake will be increased, their profits will still be strong, and at the same time they're serving all of the Hep C carrier population very well. Message for Romanian liver doctors is to treat your carriers of Hep C virus as quickly as possible, especially the ones with advanced fibrosis, and to really engage with the politicians and the drug companies to provide pressure to get these wonderful new drugs to the people that really need them. We can cure Hep C. It is the only chronic viral infection that can be cured. No other chronic viral infection can be cured. We have the drugs to do it. It takes pressure from the medical community, from the patients, from the government, and to work with the drug companies to get these drugs to the people that really need them. It's a tragedy, and it will be a tragedy if most carriers of Hep C cannot access these drugs over the next 2 to 3 years. I think with the new drugs we now have available to treat Hep C carriers, and with the diagnostics and the blood tests, we have a real chance of really effectively controlling this virus amongst the world's population. One thing we need is to develop a vaccine. The WHO, the World Health Organization, estimates there are 2 to 3 million new infections every year around the globe. And everyone knows that prevention is better than cure, so we need a vaccine quite badly. And here in my lab at the University of Alberta and in many other labs around the world, there is a lot of effort going on to develop a vaccine for hepatitis C. Our own work here in Edmonton, we expect to be in the clinic in 2 to 3 years' time. And I am optimistic. Historically, there has been pessimism about the ability to develop a vaccine for hep C, but I'm convinced it's possible. And the animal studies that we've done in the past support the notion that you can develop an effective vaccine for hepatitis C. I think it can be done, and we're working hard to do that. Of course, to control the virus globally, we need to use the drugs widely for all the patients, and in addition, we need a vaccine to prevent new infections. Every year that a hepatitis C carrier is not treated with the new drugs, there is a risk that he or she will develop some form of serious liver disease that could be deadly. So it's very important to have wide community screening to identify the carriers, first of all, so that they can be counseled to take measures to protect their livers, not to drink alcohol, to drink coffee on a regular basis, unless there's a contraindication for coffee drinking in them, such as high blood pressure, for example. Secondly, it is very important to get these drugs to every single carrier of hep C as soon as possible. While most of the disease will be preventable if we treat patients with advanced liver disease first, there will be, because of the high prevalence of the virus, there will be many, many patients that develop serious liver disease if left untreated. So this is the problem with hep C. It's not just that the drugs are expensive, it's that the disease is so prevalent, it's so widespread. So if you leave patients untreated, even though their livers are healthy today, they could come back in a year's time to their doctor with liver cancer or liver cirrhosis. Yes, I think if you do a pharmacoeconomic analysis, you can make several conclusions. And that is, if you try to save money by not treating most patients with the new drugs, initially you will succeed in saving some money. But there will be so many of those patients that develop liver cirrhosis and liver cancer, and then to treat those patients becomes extremely expensive. And a lot of the savings that you make initially will be lost because of all the treatment and all the specialist help those serious liver disease patients will need in the future. A liver transplantation is very expensive. And to treat a patient with liver cirrhosis needs an expert hepatologist to see the patient frequently and to monitor the patient frequently. It will require hospital stays, probably. And overall, it's much more cost-effective to treat all of the patients now with the new drugs. Many millions of people around the world became infected with hep C as a result of getting a blood transfusion in the 60s and 70s and 80s. Unfortunately, not enough was known about the virus then to be able to prevent that. A blood transfusion is usually given to save someone's life. If they don't get the blood transfusion, they're going to die from the road accident or from the surgery. So in the past, it's been considered on a risk basis acceptable to have a blood transfusion to save your life at the risk of getting hep C. But that said, so many millions of people around the world have been infected from following a blood transfusion that we owe it to them morally, and we owe it to them as a responsible government to make every effort to give the new drugs to make them accessible to most of the carriers of Hep C. We have these wonderful drugs. They can cure the patient. For the first time, we can cure Hep C. And a patient shouldn't be living with the threat of developing a life-ending disease when there are drugs available. Yes, there's a huge economic burden to pay, but if you actually perform an analysis of cost effectiveness, it will turn out to be highly cost beneficial to the community to do it. And as I've also said before, the first place to start is community screening. You first have to identify the infected carriers. To do that, you have to diagnose most of the people that have had a blood transfusion in the past or have experienced high-risk behavior. That's where it has to start. And then once you've identified most of the carriers, then you can start to work with the drug companies to bring the prices down so that those drugs can be made available to most of the carriers. Interferon is also still expensive. It's not like interferon drugs are 1/10 the cost of the new drugs. They're not. They're comparable price to the new drugs. I think one important message to governments around the world is to understand that while the new drugs are more expensive than the old drugs which used interferon, if you actually cost the drugs in terms of the cost per cure, the new drugs are cheaper. In other words, the cost the government would pay to cure a patient today with the new drugs is less than the old cost of using interferon. Why? Because interferon only cured 50% of the patients. Yes. The new drugs cure virtually everybody.